color being compared to the best of groups. So our maternity bundle is being implemented to not to improve health outcomes overall, but to do so with an emphasis on closing the disparity, on closing the equity gaps, bridging the gaps for people of color and those with substance use disorder. So keeping that in mind within this context of the bundle, I'll hand you over to my colleague, Tiffany, so she can continue with this presentation. Thanks, Tiffany. It's over to you.
Thank you, Fatmata. Before we dive into some background about the details of the maternity bundle, we'd first wanted to start by just grounding this group in some context and framing for the current stage where we're at in implementing the maternity bundle program. So DSS is currently targeting to launch the program at the start of next year, January 2024. This is going to be contingent on a couple of items. One of the first one and critical pieces being obtaining CMS SPA approval. Another big piece that is important for this program is making sure that we have a lot of provider engagement and awareness of this program. That also includes engaging with doulas and lactation consultants who will be participating in the bundle as well. So just wanted to set some of that framework in terms of timing for where the program is currently at. As a little bit of context, this program was designed in collaboration and through the advice of a maternity bundle advisory council, which included several community stakeholders, providers, doulas, and members as well in this program. And so throughout the beginning of this year, the big focus has been finalizing and confirming technical details of the program. That involves bringing on the Mercer team to review and confirm this work. A big part of the work we're currently doing is moving into the actuarial modeling piece. So DSS would like to do a program testing, what we're calling a historical dry run of the data. This will be looking back at 2022 claims data to see how this program would shake out if we were to do that, and make sure we can modify the program as needed and any technical details before we do that. As we finalize the program modeling, DSS is hoping to provide some historic provider performance reports so that we can give providers a view of how this program would impact them when the program is launched. A lot of the details that we want to finalize for the technical design will also be provided following the completion of this actuarial modeling and program testing to make sure that we're able to provide accurate details after we've seen how the model will play out with historical claims data. Like we mentioned, another big piece is going to be provider engagement. So we'll talk about that more later on in the presentation, but CHN and DSS will definitely be hosting more information sessions and providing opportunities for provider feedback. The other piece, just from a program implementation standpoint, is making sure the MMIS or claims processing system is ready for this new program. So a lot of that work is also underway, but that's currently where we're at in terms of program development and implementation as we aim towards that target date for next year. A little bit of background about bundled payments. So the bundled payment program is a little bit different than the fee-for-service payment model that Connecticut currently operates under, in that this model is aiming to directly incentivize coordination of care and quality improvement. Bundled payments aim to align incentives for providers and encourage collaboration to improve quality and coordination of care across care settings for the member. This approach aims to reduce silos in the member's care experience, create efficiencies that lower and manage the costs of care, and overall improve quality of care that they receive through the bundle. A key benefit of this program also for DSS is going to be adding the inclusion of access to doulas and lactation counselors, sorry. With bundled payments, there's going to be an opportunity to share in savings when costs are kept below the bundle's target price. So in the first year, DSS is planning only to have upside savings, so there's no downside risk for providers. And of course, to make sure that high quality of care is provided to members, quality members will be there as well, which have been decided through a discussion with the advisory council to focus on provider accountability and to give key performance incentives about the program to ensure high quality of care. A key goal of this program is to address racial health disparities, as I mentioned. And so DSS plans to do that by utilizing 6 key outcome measures to measure program success. These measures were selected based on the recommendation and input of the Maternity Advisory Council as key maternal and infant health outcomes to improve within the state overall, and specifically to reduce racial health disparities. So those members that we'll be tracking are NICU utilization, overall neonatal abstinence syndrome, neonatal opioid withdrawal syndrome, adverse maternal outcomes, NTSV C-section or low-risk C-section, and the overall C-section rate. And the goal with this, with these measures, like I said, is to look at the overall success of the program, so DSS can track how the program is doing and how it's impacting outcomes, and also to make sure we're tracking progress in how DSS is reducing racial disparities. DSS is aiming to do this by providing access to community peer supports, like I said, with doulas and lactation counselors, incentivizing greater care coordination throughout the pregnancy and postpartum period, through this bundled payment by moving away from fee-for-service, hoping to provide more flexibility to providers to deliver care in high quality ways specific to the needs of their members, and also encouraging the establishment of a relationship between the birthing person and their providers. So here is an overall view of what the maternity bundle is going to look like. This is described what we'd call an episode of care, which is the total time frame and the total amount of care provided to a patient during that time frame. So in this program, the maternity bundle will be spanning 280 days before birth. So that's covering the pregnancy period. Pregnancy period is going to include the typical prenatal care services that you can see in the bullets below. The maternity bundle will also include the delivery and postpartum care phase. So that's going to cover postpartum care 90 days after birth. And then in terms of reporting, something DSS would like to do in the future is to look at how newborn care can be incorporated into the bundle. So for now, in our first year, newborn care for the first 30 days after delivery is going to be included for reporting only. But that's something we'll look to see if that's feasible to include in the future, since newborn care, especially the impacts for NICU utilization and the outcomes that has on newborn care is something DSS wants to look at in the future. So during the maternity bundle, payment will be a combination of fee-for-service and also prospective payments, which we'll talk about later. Once the maternity bundle has ended that 90 days postpartum period, there's going to be some time to allow claims to come in. There's going to be some time to do some reconciliation calculations, and that's when reconciliation will begin. So in that case, all services included under the bundle, so each of those bullet points below, they'll be reconciled to a target price or the expected price for that maternity, the expected cost for that maternity bundle episode 6 months after the claims are submitted. And from there, DSS will be able to determine whether shared savings payments will be submitted to the provider. So I started to touch on this briefly, but wanted to get a little bit more clear about the payment approach for this program. there's going to be a hybrid payment approach in which DSS will pay prospectively for outpatient providers for a subset of services to the accountable provider, who could be an OB-GYN provider, certified midwife practice. In addition, for any services that are outside of that subset, not included in the prospective payment, those will be paid fee for service, and there will be a retrospective settlement of total costs in the maternity bundle to ensure that payment is made for all services rendered outside of the accountable practice. So we'll have that prospective payment happening on giving a set amount of money on a monthly basis to providers. On the back end, at the end of the bundle episode, there will also be the opportunity for shared savings payments during reconciliation. And a big part of the prospective payment model is just to be able to provide some upfront capital for practices to enable these practice transformation activities. We're hoping this gives practices a little bit more flexibility to provide care in these practice transformation activities. So with that, I will pass it on to Angela.
Thanks, Tiffany. So as Tiffany described, all OBGYNs, midwives, and family medicine practices that deliver in Connecticut's Medicaid program will be eligible to participate in this program. We're going to look at provider groups at the provider group level, not at the individual level, when calculating the minimum episode volume. So the practices who are going to participate in this program must have at least 30 episodes or 30 deliveries in the last 12 months when we launched the program. If you are a provider who is in a practice that has less than 30 episodes or 30 deliveries in the last 12 months, then you will not be part of this program and will continue to be paid fee for service for all services rendered. When attributing the bundle to a practice, the methodology will look at the practice who billed a prenatal diagnosis code that then triggers the prospective payment. And our team at Mercer will talk a little bit more about that later in the presentation. But if you are a provider or practice who bills the prenatal code that then triggers the prospective payment, the bundle associated with that patient or member will be attributed to you. There are some opportunities for, that's the happy path, or like the general path of attribution. When there are exception circumstances, attribution might change. So examples of that are if a patient changes to a different practice during the course of prenatal care, the attribution would go to that different practice. If practices are first seeing the patient in the third trimester, then those patients will also be excluded from shared savings and from the overall reconciliation process, but the prospective payment will continue to begin once that patient is begun to seek care. And pregnancies for maternity providers that do provide prenatal care but don't necessarily perform the delivery itself will be included. So on the next slide, if we then think about who is included from the member perspective or the patient perspective, all pregnant people would be included unless you meet one of the criteria on this slide. So if you're younger than 12 or older than 55, you would be excluded. If the birthing person left the hospital against medical advice prior to discharge, that bundle would be excluded from reconciliation. If there's substantial gaps in eligibility and enrollment during the episode, then that person would be excluded. If there's a facility claim that's missing, and so we can't tie the member to a delivery, that member would be excluded. And if the baby is stillborn. There are also a couple of exceptions described in the second half of the page, where if there were no claims incurred during the first 2 trimesters, the prospective payment would still be made, as I described above, for the 3rd trimester, but the pregnancy itself would be excluded from the retrospective reconciliation. And as Tiffany described, the newborn and care for the newborn will be reporting only when this program launches. And when we look at the reporting, the newborns that have a serious congenital anomaly, or where the newborn can't be linked to the delivery episode, would not be included in those reports. So in terms of overall strategy for DSS around the bundled program itself, the committee that helped design it spent a lot of time talking about 3 key design components: newborn care, postpartum care, and multiple births. So because of the importance of the goals and objectives of this program, there is a vision to be able to include newborn care in the bundle longer term. However, when the program launches, 30 days of newborn care will be included in the provider reporting only, but will not be part of any of the financial accountability component of the program. For postpartum care, where the group landed as a recommendation was to include 90 days postpartum in the bundle for the purposes of financial accountability, and to provide reporting on the postpartum period for a full calendar year following delivery, given that some health issues that may arise beyond the 90-day window would be of interest to providers when looking at trying to achieve the overall program objectives. For multiple births, the multiple births will be included in the prospective payment and will be based on a singleton birth. However, during the retrospective reconciliation, the multiple birth will be excluded from the target price and effectively paid at fee for service to be able to acknowledge and make up the difference between the cost of the singleton birth versus a multiple birth. Next slide. Thanks. So when we looked at the overall payment model and how to design the hybrid approach around the prospective payment and the retrospective settlement and true up of the financial accountability, we identified a few principles for how to consider which services would be in which bucket. So there are 3 categories of services: those that are covered services that are included in the prospective payment, those that are covered services that are included in the retrospective payment but continue to be paid fee for service, and those that are excluded from the bundle entirely and maybe ancillary to the bundle itself. So for those that are included or planned for inclusion in the prospective payment, they would be services that are provided in-house or directly by the accountable OBGYN or midwife practice. They would also be services that are sort of predictable and very and common that should happen during the course of pregnancy. And the third category is services that DSS would consider high value and that may not have been historically reimbursed for, such as doulas and breastfeeding support. So if those are the principles around what's included in the prospective payment, when we think about the total bundle set of services that will continue to be paid fee for service, but part of the target price that our actuaries will talk about, those are services that are not provided directly inside the accountable provider's practice, and services, but they are still services that predictably happen. So services that might happen at a hospital or at a specialist's office would be outside of the prospective payment. Then services that are excluded would be services that are not common during the course of pregnancy and or would be counter to achieving the goals of the bundle payment program. So next slide. So there's a lot of detail on this slide, though I know we've used it in several public settings. So this is just a slide to provide the next layer of detail to make those principles that we just talked about more tangible. So examples of things that would be included in the bundle and paid prospectively in that column A are the professional services of the maternity provider themselves, and the professional related hospitalization costs if it's performed directly by the attributed provider, behavioral health evaluations, including screenings, imaging, in-house labs and diagnostics, screenings, doula, breastfeeding support, prenatal group visits, education services, care coordination, and anything that is regularly occurring and directly provided by the OB practice. So it would be settled, but continue to be paid fee for service. So in the column A part 2, but settled retrospectively within the construct of this bundled program for services that happen in birth centers and hospital costs that are outside of what the professional fees for the delivering provider are, specialist services, pharmacy services, and any labs and imaging that are outside the provider's practice. This is not meant to be an exhaustive list. There will be a detailed set of codes that will come out, but this is in concept how the bundle is constructed. Examples of things that would be excluded in their entirety from the bundle reconciliation are in the darker gray column B. So pediatric services associated with the newborn, NICU stays, behavioral health and substance use treatment services, long-acting reversible contraception, DME, some high-cost drugs, hospital costs unrelated to maternity care, and other services that are outside the scope. Next slide. And so with regard to doula services specifically, DSS is aiming to connect members with doulas as soon as possible in in the course of prenatal care. And therefore, DSS is planning to use a dual approach for creating access and funding doulas. Doulas can get paid through the bundle, and that would be through the prospective, through a fee that's included in the prospective payment that we just talked about. Or they could also be paid fee for service directly once the Department of Public Health's doula certification is complete and DSS has the mechanism set up for direct billing. So both of those will be are planned as options in order to facilitate access to doulas as deeply as possible. And with that, I will turn it over to my colleagues at Mercer.
Thank you, Angela. Hi, everybody. This is Grace. So I will be talking a little more in details about the payment and pricing structure of the maternity care bundle. So the first slide, the slide we're looking at right now, there are a lot of information that Angela and Tiffany have talked about in prior slides, but basically for the maternal care costs, we're dissected into three main components. The first component is the prenatal and postpartum costs that incurred in the accountable provider group. Okay, and then the second component is provider group delivery costs. So those are the costs associated with the actual birth event in hospital. And then the third component is the maternity related costs that happen from some other providers outside of the accountable provider group. So those three main costs combined together gets into the full maternal related cost. But the prospective payment, as everybody I've talked about, is going to happen during the pregnancy on a monthly basis. But this prospective payment is only going to cover the prenatal and postpartum costs that for the accountable provider group. But all three components will be part of the target price we've been talking about at the end of the reconciliation process. So let's go to the next slide, and I'll get into a little bit more details of both the prospective payments as well as the target price. So what we're looking at is the methodology we use to set the prospective payment. So the goal for having the prospective payment is to give providers some upfront capital so that we encourage greater flexibility in how providers deliver care. And in addition, we also consider these doula service payments as part of the prospective payment, PMPM, as Angela has talked about. So those are for the doula services as well as breastfeeding supports. And basically on the right-hand side, we see a table where by time frame, we're looking at the pregnancy time period, delivery, postpartum, newborn. The first three, pregnancy, delivery, and postpartum, those three components will be part of the reconciliation, as I talked in the previous slides. But only the pregnancy and postpartum care that happen in-house from the accountable providers will be part of the prospective payment set. So this is the general structure and methodology we use to set up prospective payments. Next slide, please. So now we're going to talk a little more about the prospective payment timing and then triggering. So the prospective payments will not happen at the very beginning of the first trimester. So all the providers are supposed to bill regularly, just as normal as fee-for-service payments. So they will have all the services billed on the regular by claims. But during the first trimester, nothing will happen. Just get paid as fee-for-service as regular. But starting from the second and third trimester, if there's any trigger codes that show up in one of the, on claims, then this fee-for-service payment structure will stop, and then it will be the prospective payment PMPM will happen. So all those claims that get billed regularly during the second and third trimester will get zero pay. Instead, the providers will actually get this prospective payment PMPM that's preset to cover all of supposed to cover all of their all the members' prospective, the prenatal and postpartum care cost. So, and then for the timing, the prospective payments, as I said, will be made every month from the beginning of that trigger code get building to the end of the 90 days postpartum. Or if there's a claim coming in that carries a code indicating pregnancy was miscarried or terminated, then the prospective payment will also get stopped. But overall, it will cover like from the second or third trimester to the end of the pregnancy and 90-day postpartum. Next slide, please. So now we can talk a little bit about how do we set up the prospective payment amount. So overall, the prospective payment is aiming to cover the prenatal and postpartum care costs. So what DSS and Mercer will do is to take each provider's historical claims for the prenatal and postpartum care, and then calculate the provider specific cost PMPM. And then there will be a additional add-on PMPM on top of what we've seen during, based on the historical claims for prenatal and postpartum care for the doula care and breastfeeding support. So on top of the regular PMPM, there will be an additional add-on PMPM for the doula and breastfeeding support. Right, next slide, please. So now we finished talking about the prospective payment PMPM. Now we're going to talk about the provider specific target price. As I mentioned earlier in the first slide, the target price is aiming to cover the whole maternal care cost, including the prenatal, postpartum care, including the actual birth event cost, and all the maternity related costs happen outside of the OB provider office, right? So this target price for each provider will initially reflect a 50-50 blend of the statewide cost and the provider specific data. So it will, that's what happened in the beginning, but overall, like down the line, we might switch to some different structure, maybe a different blend, or ultimately maybe just be provider specific data. But for the initial year, it will be a 50-50 blend of statewide and provider specific data. And then when we price the maternal episode cost, it will actually, we won't necessarily completely rely on what was billed on the claims. Instead, for some specific services, as well as some inpatient hospital costs, we will use a standardized hospital-based price and some standardized pricing so that we can kind of, avoid big pricing gaps between different providers. So we're going to reprice some of the claims if, those for certain type of services, those costs differ quite like a lot from provider to provider. So we'll have some reprice going on when we set the target price. Next slide, please. And then also we do understand for each providers, the members' acuity can differ quite a bit. And then also the members' social risk will also differ quite a bit among providers. So we will be incorporating the clinical and social risk adjustment to the target price to kind of take into account the member acuity differences. Also to ensure the reasonable trends and program stability, the target prices will also be adjusted when it's necessary for actionable adverse event costs or C-section rates, because we do understand C-section is more expensive. So if a provider tends to have more C-section, those rates will also be incorporated into setting the target price and some other factors when we see them. So next slide, please. So after we have the prospective payment PMPM going on during the course of pregnancy and postpartum, and then we set the target price at the end of each year, at the end of the attribution period, we will be reconcile the ongoing, prospective payments, all the costs together against the target price we preset, right? So we consider the target price sort of as a benchmark pricing. So all the costs related to maternal care will be compared against this benchmark price. And then as Angela and Tiffany mentioned earlier, during year one, there will be only upside savings. So there will be only savings distributed to accountable providers. There will be no loss, no penalty, but overall later on in later on years, we might have some costs that will be recouped from the providers. And then these, when we count for the whole entire maternal care cost, it will be 200 days, 280 days prior to delivery date throughout to the 90 days postpartum. So they will be all combined. Then we'll also consider the quality performance to calculate the share savings. All right. So that's, I will hand it over to Dr. Richards for the next slide. Thank you.
Great. Thank you so much, Grace. So I just wanted to touch base on the quality measure set for year one. And so there's 5 notable pay for performance measures here, and then 5 that are pay for reporting. I'll make note that the first 5, what they're very much related to some of the outcome measures that we'll be monitoring for the overall success of the program. The ones I'll specifically call out: the maternal adverse events. This is based off of an NQF measure that has been slightly modified so we can use it as a claims-based measure. We're using cesarean birth rate of individuals, of C-sections among NTSB deliveries, a low birth weight, which is an existing DSS measure, which we've used for OBP for P, a prenatal care measure, proportion of pregnancies where first prenatal care visit occurred in the first trimester, and postpartum care 1, which is proportion with at least 2 postpartum visits within 7 to 90 days after delivery. And I'll just note that we had the pleasure of working with the Yale core team, who helped us think through some of the measurement aspects here. Just of note, we will be looking to revisit these as we move forward after year 1 and come back to think about how we're structuring this in terms of pay for performance versus pay for reporting. The pay for reporting measures, there's again 5 of them. One is doula utilization. That proportion of births attended by doula. We will be looking to capture this similar to how we're capturing some data through OBP for P, with a encounter form that will need to get submitted to CHNCT. And we're kind of working through how this will work in the future, but in terms of whether we modify any shared savings based off of that. But again, as of year 1, we are keeping it as a pay for reporting. Breastfeeding, similar, we're looking to identify those who are newborns that are exclusively being breastfed, and especially during the entire first phase of the hospitalization. There's a behavioral risk assessment looking for individuals who are screened during the 12-month period that for things like depression, alcohol use, tobacco, drug use, and inter-partner violence. And then there's a preterm birth, preterm labor measure that we'll be looking at as well. And then a contraceptive measure, which is the proportion of individuals who have a LARC in the postpartum period. And so again, these are kind of what we've identified for year 1. We'll be looking for feedback as well as monitoring those over time with a plan for looking and revisiting that for year 2. I'll pass it back over.
Thank you. So when we then look at how to convert the quality scores for each individual quality measure into an overall quality score for this program, DSS has come up with a weighting scale that looks at maternal adverse events and the cesarean birth measures as the highest priority in order to tie back to the overall goals and objectives of this program. And so those 2 measures will be weighted a 3, or at the top tier. The pay for reporting measures will be weighted a 1, and all of the other pay for performance measures will be weighted a 2. And so we will then score each of those measures individually, multiply it by the metric weight to then get an overall quality score. When we look at the next slide, it's providing a lot of detail about an example scenario that that you can, go through offline as interested. But I think the key takeaway for the purposes of this forum really is that the quality score calculation, when we look at the applying the weights that we talked about on the last slide, will result in 2 scores. One is, what is your overall performance quality score? And so that quality score will be just how is your performance? And the second will be looking at your improvement. How much has your quality score changed from baseline and year over year? And so using those 2 quality scores, the distribution of shared savings will be adjusted, and the specific methodology by which the final scores will be attached to payment will be worked out through the upcoming actuarial analyses and implementation phase. Next. I think I will hand it back to our Mercer colleagues.
Yes, hello. Thank you, Angela. This is Sean. Building upon everything that you've heard so far, we also want to make sure to highlight, as we have thought through the model, that it's important to take into account the variable levels of risk for individual patients. Therefore, the model will include the application of a risk adjustment that captures the clinical risk level of each individual patient, and then would estimate the impact of cost on the episode of care. This will both include maternity health factors and social factors, which would be considered the independent variable for each patient, and the per delivery cost, which would be that dependent variable as we build that into the calculation. The health factors and their weights form that health proportion of the risk score, and then those social factors, which we'll be using initially the area deprivation index, which is that ADI, and their weights will then form those social portions of the risk score. That risk score is then that estimated impact that I mentioned a moment ago. The general idea is that those episodes of care that have a higher risk score than 1 would likely have more cost than the average, and those with a risk score less than 1 would likely have those expected costs to be less than the average. And so based on what we heard Grace talk about earlier, as well as the Faulkner group, this would be built into the model and the calculations. So if we can go to the next slide. So to provide a little bit more information, particularly on the area deprivation index, we're proposing that that's what will be used in year 1 for the social risk adjustment. The ADI generally is representative of reflecting a geographic area and the level of socioeconomic deprivation in that area. And then that is associated with health outcomes to identify and screen patients for various social determinants of health. So the measure in particular will be ranking things such as the relative income, education, employment, and housing quality within those regions in the index scoring tool. A low score, as I mentioned before, would indicate more affluence and less impacted costs than the average, and a high score would indicate higher levels of that deprivation and likely increased costs above the average. The specifics of, sorry, I switched my page. The specifics of how the index will be used are still being worked through, but the factors such as hospital cost differences will be removed to not influence the adjustment. This is another area that we'll be thinking through further as the dry run is completed. Risk adjustments will be applied in a budget neutral manner, which is important to note. So what that means is risk adjustments will pay providers with a higher risk patients more compared to those providers who are serving lower risk patients. And that ties back to that scoring concept we talked about on the last slide. And then as we move forward, this will be reevaluated and considering potential new data as that becomes available. There could be other adjustments, but for a starting point, we're looking at that ADI. If we can go to the next slide. Another component that we want to make sure we stay ahead of is under service utilization risk. And so a plan is being put together in response to help mitigate potential risk. And as an approach is designed, we'll be looking at things such as identifying potential under service utilization or inappropriate reductions in potential access to that medically necessary care. So as I mentioned, this is in development, but some key things that the plan will address, it will have a risk mitigation component as well as a monitoring and oversight component. And some things that we would be considering is carving out specific services to prevent a reduction in the utilization of specific services. Also looking closely at the quality measures to drive improved outcomes and increase perinatal services that monitor or encourage service utilization. That, as was mentioned earlier, may include things such as adverse maternal events, prenatal care, postnatal care, C-section rates, and low birth weights. The time frame of the bundle will also be looked at, wanting to make sure we're in the future increasing provider accountability and preterm and postpartum along the episode of care. And then related to monitoring and oversight, similar to the approach and the plan that was put in place for PCMH Plus, we'll be looking at ongoing claims monitoring, but be targeting that monitoring specifically to the maternity bundle program. We'll also be considering other strategies of support of the assessment of the members' experience directly, as well as identifying individuals who are financially expensive for providers from that historical fee-for-service data, some of which will be looked at in the dry run to help inform our plan as we go forward. Okay, I think now I am turning it back to Tiffany.
Great, thank you, Sean. So like we mentioned at the top, DSS wants to provide ample opportunity for stakeholder engagement. That's a big part of the reason that we've extended the implementation of this program to ensure that feedback from the community and from providers are taken into account into this design. So just last week, we hosted 2 doula-related webinars. Those recordings will be posted on the DSS website if you weren't able to attend, so that information will be shared out. We have this provider forum today, and we'll be hosting additional forums in the fall, particularly as Mercer completes the dry run and program testing. We'll be able to provide more details, more technical details on the program, so specific trigger codes, specific payment policies and processes, anticipating that in the fall. We're also putting together some documents to give guidance on specific services like doula services, lactation supports, and also some FAQs and information around prenatal group visits, if that's something your practice is interested in providing. So that's also aimed for the fall. The provider performance historic reports. This is going to give a lot of really good insight into provider performance, anticipated rates for what they can expect, and the impact of this program, looking at 2022 claims data. So that's also anticipated later this year. And then, like I said, more provider opportunities to have conversations with providers through this forum basis will be given later in the year as well. And as well, just to provide more education about the program and answer any questions that providers might have. As necessary, like I mentioned, we did design this program in consultation with an advisory council. So that council will also be called forth as any program changes need to be made as well to solicit feedback before program launch, and also once the program has launched to give regular reports on how the progress and the design is going with that. So I think that brings us to our Q&A session. I will pass that over to Brad to field any questions that we've received in the chat so far. And also wanted to acknowledge we did receive a lot of good questions from folks through the registration form. So we'll be aiming to provide some written responses to that following the meeting, as well as incorporate those into FAQ documents that will be distributed later this year.
Thank you, Tiffany. And just as we're joining us as a reminder, just fielding questions right now through the chat, and I've received a few as of now. And I just wanted to thank the team members on here for helping pull this together and all the work that goes into it, including Tiffany and Angela, Grace, John, Fatmata, and also our collaborators on previously, primary maternity care, who'd helped us with a lot of the doula integration work, as well as CHNCT, who's helping host this and has been instrumental in us pulling together a lot of these details, as well as the advisory council, which has been extremely helpful in providing advice to DSS as we work through many of these, many of the questions already. And I know we're planning on continued engagement as we look to roll this out in the future. That this, again, won't be your only opportunity to weigh in. We'll be looking for further opportunities to get feedback. And so, and just as Tiffany mentioned, we did receive some questions ahead of time. I think some of them were addressed as part of this presentation, but we are planning on incorporating some of those questions into our published material. So we will have some written responses as well. Just we're trying to have an FAQ to make it easier for people to find answers to common questions. And so that is in the works. I'm gonna go ahead and start at the top. And I think there was one question about getting a copy of the slides that, yes, definitely will be, and we'll obviously also be publishing a copy of today's meeting as well, so others can review this in the future. So one question, the one person was, will multi-credential providers such as doulas, childbirth educators, community health workers, lactation consultant providers who are not employed within a hospital or OB midwifery practice that are providing multiple services such as IPV, delivering childbirth education, providing doula lactation services, be eligible for funding of each service under the prospective payment plan. So the payments, as we've structured it now, are to providers who kind of were outlined. So certified nurse midwives, OBGYNs, any family providers that are practicing delivering, again, meeting the credentials as previously discussed. That's that prospective payment. The additional payment on top of what we will kind of based off of the historical, looking back, partially based off of historical payments, is additional doula and lactation support. We are providing general guidance to providers as to what we'll be looking for in terms of those lactation supports. So for lactation supports for doula providers or for doula services, we're recommending that providers will be using the Connecticut Department of Public Health's guidance on who will qualify to be certified in the state. And so we're really going to be deferring to provider practices to determine who they're going to be working with to meet the goals of providing doula and lactation support. For separately, as noted at the top, for doulas, we will be paying out also outside. There's two mechanisms here for doulas specifically to potentially have their services reimbursed. One is directly working with providers who will then get some reimbursement or payment for those doula services. However, we're going to have a separate pathway where we will be looking to enroll fee-for-service providers through a fee-for-service mechanism once the DPH certification process has been finalized, which legislation was recently passed, and Fatmata, who's on, has been involved working on the DSS side with our DPH partners as part of the work that's gone into that. And so that's essentially how we're structuring these payments as of now. So those are kind of the two methods for doulas specifically, and those providers are going to be getting reimbursement for additional lactation and doula per member per month amounts on top of their historical payments, on top of the PMPM that's based on historical, partially based on historical spend. Subsequent question regarding who qualifies as a doula. So related, is state certification required? Also similar question for lactation counselors, consultants, what certification licensure is required? So just specifically on doulas, who qualifies? For providers who are working directly with doulas, we'll be recommending following the CT DPH guidance, but we will not be requiring that. For doulas that are looking to directly enroll with Medicaid, or either they directly enroll or organization directly enrolls is able to bill for doula services directly, we will be looking to follow DPH guidance off of that. And so that will be part of the requirement is certification through DPH. For lactation support services, there will not be a requirement. There's not at this time direct payment for those services. Those services will be paid to providers, and we'll be looking to provide guidance to providers in terms of what services should be provided and to who. But there will not be direct, at this time, at least directly enrolled lactation support providers. It will be through that bundled payment to providers directly. Next question is on ADI. ADI is not assigned to an area when there is a high presence of group housing, such as area of Hartford Home, to house of Bread and My Sister's Place. Do you have an update on how you'll calculate the social risk adjustment for these locations without an ADI? So this has come up. So area deprivation index, the ADI, there are certain areas that are not assigned ADIs for a few different reasons. We're still finalizing with CHN, CT, and our Mercer team to have a recommendation for anyone who's familiar with the ACO REACH model. They have essentially are using ADI for some social risk adjustment. It really will depend on the number of members who do not have an ADI. We obviously don't want to penalize providers who have a high proportion of members who have ADI that's not that do not have an assigned ADI, and so it really depends on the level. If it's very small, it's relatively easy. If we have a large number of individuals that will be identifying as kind of part of this historical run, we'll have to reassess whether we can use that same adjustment model that the ACO REACH program. Again, that's a program through CMMI, Center for Medicare and Medicaid Innovation, that's also using ADI for social risk adjustment. So we don't have an official determination yet, but we are still finalizing a recommendation there. I do not see information of breastfeeding support, how's it defined, who can provide it, and how quality of support will be measured. Will reimbursement for clinical lactation services follow a similar path as doulas? Will DSS be engaging with IBCLCs within CT regarding participation? I think mostly answered this. As of now, breastfeeding support individual, including IBCLCs, are not able to directly enroll as providers. And we will be paying for lactation support services through that bundled payment, a portion of, and I should just say the amount out loud because it's always good to be really concrete. So it's 21 total additional per member per month amount, with $14 set aside for doulas. 7 of that is lactation support services. And as of now, we'll be providing general guidance to providers, but really deferring to providers to determine how to utilize those dollars most effectively. We will be looking to capture information about success of lactation as part of the encounter form, and then looking to potentially readdress how we're handling lactation support after year one as we evaluate the effectiveness of what we're doing. So just to say, we're interested in increasing breastfeeding support. We are providing some additional resources. We are going to be interested in seeing how effective it is, as well as reevaluating if there's ways we can make this more effective in the future. Sorry, if you mentioned this, can larger groups, 30 or more, opt out, or they automatically enroll based on encounters? So if you meet the 30 birth threshold criteria, then providers are automatically enrolled. So it is a mandatory program for those who meet the criteria. Is the measure source national or Connecticut based? I think this might be referring to the quality measure specifically. So the measure sources are a mix. So a lot of NQF measures for those who, and I should go back and reference this, that our existing OBP P4P or pay for performance program that many of you may be familiar with is being extended. As we were initially planning on launching the program in this July, we are extending it through closer to the end of this year. There'll be information forthcoming. And some of these measures we've used historically as part of the OBP program, which you might be familiar with. So just in terms of measure source, that is listed in here. Will this new model increase the RVU component for physicians? So there's no change in RVUs. Will be a PMPM based on partially based on historical utilization, as Grace mentioned. Grace, I don't know if you want to add anything else to that, but it really won't have any impact on RVU. It's a per member per month model with retrospective reconciliation. So there is the opportunity for additional dollars for providers to bring that in through the shared savings approach. Let me just see if Grace is on, if she wants to add anything else.
No, Dr. Richards. So yeah, I don't have anything else to add on it, but yeah, basically the prospective payment will just, again, for not including hospital, the actual birth event, but for the prenatal and postpartum care, using historical data on the provider specific level to calculate the prospective payments. And at the end, when we do reconciliation, any overpay or not, I shouldn't say overpay, all the payment will be reconciled against the target price. So, we try to make the prospective payment PMPM as close to, actual as possible, but towards the end, but understanding it's based on historical payment, those might not be exactly the same as the actual, or services incurred, but towards the end, we'll do the reconciliation and, the add-on PMPM for lactation support, actually not for lactation support, for doula care will be reconciled on its own. So yeah.
Thanks, Grace.
Dr. Richards, we do have someone with their hand raised.
Yes, I'll get through the questions, and it might be typed in here too. And I'll just read them out loud if that's okay. So, but thanks for acknowledging, I think, and we'll, if we have any questions afterwards, I just want to make sure to get through things. That some of these came in a little while ago, I think. This topic is complicated. Are you saying providers get reimbursed less for adverse outcomes like low birth weight, preterm birth, or first visit after first trimester? And maybe go up to the slide that I think Angela covered a little bit about how the impact of the quality measures, or I think a couple down. I think just to be clear, maternal adverse events, we're looking for less, right? We want to see lower adverse maternal events. And so we'll be and similarly, like we're looking for avoiding unnecessary C-sections. We're looking for increased postpartum, increased prenatal care, and lower low birth weight percentages. So essentially, as you would imagine, we want to see lower maternal adverse events. These will be calculated and scored in such a way that whether it's, as Angela kind of outlined, it creates a gating effects to shared savings. So we're looking to improve quality measures to make sure that we're making sure that providers are focused on that as part of it to increase reimbursement as part of shared savings. We think there's win-wins by reducing adverse events, lowering C-section rates from where they are, that those can help reduce costs, and that there's win across the board, including for pregnant individual, provider, as well as state DSS. And so that's kind of how we try to orchestrate that. Please define broad spectrum lactation support providers concerned regarding variability in care and credentials, unlike doulas who would be credentialed through DPH. Please clarify. So as of now, there's not a certification process through DPH for lactation support providers as at the moment. We will provide very general guidance in terms of what we're looking for. Our end outcome is obviously increasing breastfeeding. I suspect that's a goal that probably most, if not all of us share, is to see more individuals increasing their breastfeeding rates. And so we're going to, we have to work on trying to capture that data effectively. DPH, Department of Public Health, has some data. We're trying to figure out how we can improve our data collection, which is part of why this is a pay-for-reporting measure. And then trying to figure out how do we actually increase those rates and incentivize that. I know the question is a little bit about lactation support in terms of who the providers are. We will provide general guidance, but again, we will be providing flexibility to providers in terms of how they decide to use the additional dollars to improve breastfeeding rates. For lactation support, if we provide services outside the 90-day postpartum window, we'll be able to bill for service. As of now, the answer is no. It's the episode will end after that 90-day period, and the additional funding will stop. Obviously, we know that breastfeeding is important in that additional period, and that's part of the reason we're looking to gather data for 12 months postpartum. One of the considerations that we need to keep in mind as we design this is how do we make that incentive effective? And it may not be something that we want to do as part of the bundle. There may be another process. And I think as DSS, we're open and interested in thinking through that process. Obviously, there's some challenges to secure funding, other process pieces that we have not worked through the details on. But generally, I think we want to see individuals breastfeeding for longer. We want to support that. There'll be some challenges with figuring out how do we most effectively do that in the long run. And so right now, at least as part of this bundled episode program, it does end at 90 days postpartum. Will perinatal home care skilled nursing be part of maternity care outside of the bundled care plan? Mata, is that something you could help answer? I don't know. It's will perinatal home care skilled nursing still be part of maternity care outside of the bundled care? There's no changes to that.
Yeah.
Yes.
Yeah, there is no changes to that. That's a benefit that's there that exists. It will not be like part of the bundle. That's a home care service.
To clarify, you're going to pay the OB practice a set amount, and then we'll need to develop a mechanism to pay the dual lactation childbirth professionals for their service. So the answer is yes, in terms of the mechanism to pay for dual and lactation professionals. So one is for doulas, we recognize that, especially off the bat, not all providers are going to have doulas on board. There's a limited, so again, a lot of the work that primary maternity care did for us was assess the doula landscape. There's not going to be enough doulas available to provide doula services off the bat. And so it will be something that we're going to be monitoring and interested in over time. We will be paying a PMPM upfront as part of that to providers. That 14 of the $21 additional dollars that we're adding on, 14 of that is for doula services. That $14 is at risk, which means that if there's a doula that's not used, we will take those dollars back at the end. We just want to make sure there's upfront funding for providers, but we also know there is some administrative burden on providers to do this, to build relationships with doulas. We do think that there is a benefit, and that there is, I think, reasonable data to suggest that doulas utilizing doula services can help reduce adverse maternal events as well as C-section rates, which ultimately can lead to improved outcomes and potentially shared savings for providers. And so and one of the things that PMC, or primary maternity care, has helped us with is think through some of the process pieces and guidance that we'll be providing. So just to acknowledge, the payment is there. It is up to the providers to work out how they're going to be working with lactation support providers as well as doulas. In regard to lactation services, are you saying that the OB or certified nurse midwife providers will hire a contract with IBCLCs or CLCs to provide these services? Yes, essentially that would be what we would be looking to have the providers be the ones to help. Either, and some providers have, for example, IBCLCs, or contracted with other providers to provide services for lactation support. And so we would be looking to enhance those relationships for providers, and for providers to make new relationships as needed, acknowledging that, some of this, we know that we're launching, when we launch this, some of this will take a little bit of time to get traction for people to be comfortable with it. We know that some of these things can't happen overnight. We want to give, part of the reason we're talking now is to make sure that, and also extended the launch, is to make sure people are aware that this is coming, and so they can start doing some of the work and thinking through some of these process pieces, because we know it won't happen overnight, and it is something that does take some administrative time to think through. How is the amount doulas are to be paid determined? Do you have any idea of what that amount would be? Yes. And so we have a fixed amount of funding available for doula lactation support at this time. We looked at how other states were paying doulas. And again, there's two mechanisms that doulas would be reimbursed. One is directly through providers. The other one is through fee-for-service. They'll can be paid through fee-for-service. We've essentially said it's about $100 per visit, and up to 4 visits, and $800 to attend the birth. That's $1,200 total for total doula services. That is, again, can be paid on the, and so let me just specify a little bit that, again, we're still working through the process of enrolling doulas directly. That will take a little bit of time. That is also dependent upon the DPH certification process. That is for direct reimbursement for services, whether that's through another organization or, whether doulas are enrolled directly or not. And then through the bundle itself. So there is a portion of the PMPM, that $20 PMPM, the $14 that's for doulas specifically. On the back end, that $14 doesn't add up to $1,200. However, we will do a kind of retrospective reconciliation specifically for the doulas to say, like, how many doula services were provided, and then make providers whole on the back end for that. So if they've contracted or working with a doula, they will receive a payment at the end as well that will be reconciled with that $14 PMPM for doula specifically. I know it's potentially a little bit complicated. Our goal with that is to provide upfront funding so that providers aren't out for all the doula services. If they have a contract and they're doing this, and you might be asking, well, why are you paying both for doulas through the bundle as well as potentially through fee-for-service? And really, our goal is to make doula services more widely available across the board. And so really giving multiple options for it. And we do think that having doulas and providers working closely together underneath a payment model, it encourages collaboration, and we think over time is actually really beneficial for providers as well as the pregnant individual. I think we all know, as a primary care provider myself, I don't do maternal health, but that sometimes when we pay fee for service and we have fragmentation, it can be harder to collaborate. And so we see both of these as viable solutions to increase dual utilization at this time. What kind of racial equity training will be required of providers? Really good question. So as of now, there's not any necessary that we are requiring. I think we are very much of the opinion that that can be really, really important as we're thinking about trying to address racial equity and health equity in general. We know that this is a big component of the program as we're thinking about trying to address this, making providers aware of biases that we all have, and how do we improve the care for individuals that have historically been marginalized in healthcare and in society at large. And we're looking to, I think, mostly to providers to hopefully engage in this, and we'll be thinking about, I think, this more thoughtfully as we move forward. We're trying to balance the adding additional requirements, but also kind of holding providers accountable for specific outcomes. So it's a balance here. Fatma, do you want anything else to that?
No, Brad, I think you said it, you said it well, because it is at the forefront of our minds, and we have been discussing whether we may even look for resources and maybe publish those on the Maternity Bundle website, or maybe use CHN's portal, to advertise, trainings that may be available, and maybe even connect with CHA to see what's available. So we are thinking about it because it is important. So, and you made that point already. Thanks.
Thank you. For a large practice, each provider will have a different reimbursement amount. Is that based on delivery clinician? So for larger practices, the rate will be based, actually, Grace, do you want to take this? You probably should, instead of having me do it.
Sorry, Dr. Richards, could you repeat the question one more time?
Of course. For a large practice, will each provider have a different reimbursement amount? Is it based on delivery clinician? Now, happy to say one sentence and pass it over to you. So the rate, the PMPM rate should be based at the TIN level, the tax ID level. And so there may be multiple providers, and they will receive a average PMPM for that historical spend for that at that TIN level. You want to modify that at all, Grace, or add any more context?
No, that is actually what I was thinking as well. So we'll aggregate to the provider at the tax ID level, and then look at the historical data, calculate an average PMPM.
Thank you. And it's based on the attributed clinician, which is what we discussed earlier. So attribution has to do with what's happening in the prenatal period, not based on a delivering clinician. So just keeping that in mind, that the attribution methodology is in the prenatal period. So different delivering clinician could occur, and you could still have attribution. We know that obviously different in practice today, there's a lot of variability in who actually delivers the newborn or attends the birth. I do not think that breastfeeding intensity and duration is routinely captured in most EMR. Could be pediatric practice, or if it is not routinely tracked. There are differences in levels of breastfeeding support, i.e. peer counselors, certified lactation counselors, and IBCLCs, and this may need to be taken into account as this can impact outcomes. Definitely, I think we agree and acknowledge that, and that there's definitely challenges with capturing the data, which I think is part of the challenge, is making sure we have accurate data. If we're most interested in trying to monitor outcomes, this is a huge piece that I think we don't have a solution to at this time. Even if we did have EMR access, as noted, electronic medical record access, the data even there is going to be limited, because how effectively is that being captured? I'm sure that may be something we look to incentivize, but actually getting access to that is something that I'll just say we at DSS are very interested in. Some of you may be familiar with the Health Information Exchange. I'll just take a moment to mention it. As Connie may allow better access to some clinical data that we could use to inform outcome information for some of these measures. We're not at that place, but that's something we're very interested in thinking through. During year one, we'll be including non-DPH certified doulas for fee-for-service payments. So to be directly enrolled, so again, just to say again out loud, the two mechanisms for potentially paying for doulas would be through the bundle directly to OB practices, certified nurse midwife or family medicine, those practices directly, who would then be responsible for determining how they're going to work with a doula provider. The other mechanism would be getting paid directly or via another source for those services via DSS. We will not be planning on enrolling non-certified doulas. We will be planning on using the DPH certification as a marker as part of that certification process. We use this similarly with other enrolled providers, including with violence prevention professionals. And we haven't determined how we'll be doing this with community health workers, but I assume we'll be looking for something similar to how the certification that kind of says, yes, you've gone through some process, acknowledging there's some challenges with, more lay doulas, et cetera, that have been providing these services for a long time. But just for ease of implementation, we will be looking to use the DPH process for that. Fatmata, anything else you want to add to that?
No, Brad, I think you covered it all. Thank you.
How will future APR DRG changes be factored into the calculation settlement? I might pass that, Grace, to you. And maybe something we need to bring back or answer separately.
So for sorry, Dr. Richards, is that about the risk adjustment piece?
It might be, so into the settlement. So I think it's on the shared savings calculation, I believe. So how will future APR DRG changes be factored into the calculation settlement?
Yeah, so I think that is some question I think we still need to sort out. But I do think, as I mentioned earlier, some of the hospital services and other specialty services will be repriced instead of using what is billed on the claim. So when there's the hospital APR DRG pricing change, if those are, those pricing impact those special services or the hospital service costs, then those will be reflected into our target price setting. But for other services, we might just still use what is billed on the claim historically. So but there's also going to be trend, as I mentioned earlier. So the trend could reflect some of the general pricing changes as well. So the details, like I said, we will probably figure out more and provide more information after the dry run. But it is some of the pricing changes will be part of the consideration when we do our target price setup.
Thanks, Grace. One other thing on the doula front I just wanted to mention is that's part of the work that PMC, Primary Maternity Care, did, is that there is a toolkit for helping with the doula integration part of this that practices can use so that you don't have to invent all of this work from scratch. And so that will be made available to providers so that you're not just having to figure it all out on your own. PMC did a lot of this, I think, to making it much, much easier for providers to do this and to integrate doulas. So that will be available. Next question is, how will you account for internal adverse events as a quality metric for higher acuity medical centers who receive care for the sickest patients? So this is a risk adjusted measure. It does have a risk adjustment component to it. And so that is a part of this. Now, the question I think is, is it risk adjusted enough? And I think we'll find a little bit of the data as we do our dry run with the quality measures that CHN and CT is calculating, and then the historical dry run reports to give providers an idea of how they will perform both from a quality standpoint as well as a cost. And so we'll be looking to discuss that as part of that release in the coming months.
Dr. Richards, this is Kim. We're approaching 1:30 in a few minutes.
Thank you for the reminder. Try to get through the few more questions. For anything that we can't, I'm happy to take this back and try to make sure we answer it as incorporated into our FAQ for written response so that there'll be more information provided. So one, before we react, and just appreciate all the questions. This is really helpful. Thank you all so much for engaging with us and providing thoughts and comments. And if we didn't get to it, we definitely will try to make sure we get to some of these other questions afterwards in written response. Let me make sure I get to the right one. Do you estimate that OB doctors will make more or less than they have historically under this model? So I'll just broaden this to certified nurse midwives and other providers as well. We hope the answer is yes. We think that this can be win-wins across the board. We acknowledge that we're asking more of providers, but we do think that there's substantial opportunities to improve outcomes as well as increase reimbursement for providers as part of this. This is part of what we hope the dry run will really demonstrate to providers, is how this will impact them and provide an opportunity for you to see how you would have done historically without any changes. And so you'll say, okay, well, I would have done X if you're based on data previously, and then we want to help provide opportunities and kind of say, here's how you might be able to perform improved performance moving forward. We'll be looking to provide so while we're doing the reconciliation process where we do these calculations yearly and do those additional payments, we're going to be looking to provide quarterly reports to providers to let everyone know how they're doing on a more regular basis. So you don't have to wait that full year to determine how you might be performing. So those will be like kind of interim or draft. And we do, so as a provider myself, as an MD, I do think these types of models, I hope in the long run, will encourage more providers across the board to participate. I think we're ultimately hoping to provide more flexibility in the long run by doing this. And I think obviously we'll see how this goes, and I can understand some of the concern or skepticism that some folks may have. But I think our goals do include hopefully giving providers more flexibility and potentially more opportunities to do the things you want to do, which is, I do think, improve outcomes, have more resources to do it. And I think that this is a step in the right direction for that. So I know we're at 1:30. Again, thank you guys so much for being here. We will post this. We'll post the slides. Mata, any final words from you since you kicked us off?
Oh, no, thank you everyone for giving us your time, and thank you for partnering.